We'll be breaking down all major concepts covered on the exam, like imagine sitting across from an elderly patient, looking them in the eye, telling them they have leukemia, and then just sending them home with instructions to do absolutely nothing. I'm Harvey.
And I'm Donna. We're expert MCCQE reviewers, and our entire mission is to help you, the Canadian medical student, feel totally comfortable and confident with the exam review process.
Exactly. And for today's deep dive, we are pulling strictly from reliable StatPearls articles. We're looking at section S06 HEMATOLOGY, specifically diving deep into chronic lymphocytic leukemia, or CLL.
Right. And just a quick disclaimer up front, this is strictly for medical education, not medical advice. Any actual clinical decisions always need to involve a qualified healthcare provider.
Always. So let's jump right into the clinical vignette. When you're looking at board questions, you'll almost always see CLL grouped with SLL, which is small lymphocytic lymphoma. And I always like to visualize these as literally the exact same actor, just playing a role in two different stages.
I love that analogy. It's so true.
Right. Like, if the monoclonal B cells are circulating in the bloodstream, so they're taking center stage in the peripheral blood, it's CLL. But if those exact same malignant cells decide to throw their party inside the solid tissue of the lymph nodes, then we call it SLL.
Yeah, the distinction is purely anatomic. I mean, if you look under a microscope or run flow cytometry, the cells are totally identical.
Just different zip codes.
Exactly. And when you're reading a vignette, the patient walking into the clinic is almost always going to be older. The average age of onset is around 70.
Yeah, you aren't seeing this in pediatrics.
No, definitely not. Epidemiologically, it's actually the most common adult leukemia in Western populations. It makes up like 25 to 30% of all U.S. leukemias.
Wow.
Yeah, and demographic-wise, it's more common in males, though females tend to get a more aggressive form when they do have it, and you'll see it very frequently in Caucasian and Eastern European Jewish populations, but it's remarkably rare in Asian demographics.
Which really points to how massive the genetic component is here. Like, first-degree relatives have double the risk of developing the disease.
Oh, for sure.
And we often see it presenting maybe 20 years earlier in the second generation, which is a huge clue.
Huh.
But I'm also thinking about those environmental links they love to test on. Things like tobacco use or being a uranium miner or Agent Orange exposure.
Yeah, those are classic secondary triggers. They love sneaking Agent Orange into a question stem.
They really do. But I guess my question is, if this is fundamentally a genetic mutation of B cells, why do we almost exclusively see it in older adults? Like, why practically never in children?
That's a great question, and it really comes down to the pathogenesis. It's a very gradual, multi-hit process. It takes decades for these specific genetic errors to actually accumulate.
Okay, so it's not an overnight thing.
Not at all. The initial precursor stage is called monoclonal B-cell lymphocytosis, or MBL. Basically, the patient develops this tiny clone of abnormal B cells.
Like a quiet little sleeper cell.
Exactly. And it can just sit there totally indolent for maybe 20 years. It isn't full-blown leukemia yet. It takes further genetic hits over time to finally push that MBL over the edge into clinical CLL.
Which makes total sense. That gradual, multi-decade buildup perfectly explains why the classic exam presentation isn't, a patient crashing in the ER.
Right, they're usually fine.
Yeah, the vast majority of patients are completely asymptomatic. The classic vignette is like a 72-year-old coming in for a routine annual physical. They feel great, but their CBC just incidentally flags this massive lymphocytosis.
And the reason those cells accumulate so slowly is because the core problem isn't actually rapid, uncontrolled proliferation.
Wait, really? It's not rapid division?
No, it's failed apoptosis. That's the key. These rogue CD5 positive B cells essentially just escape programmed cell death. They forget how to die.
Oh, wow. So they just stick around forever.
Yeah, they refuse to die. So they slowly, continuously divide and pile up in the lymph nodes and then eventually spill over into the blood, the spleen, and the bone marrow.
Okay, so that leads us to the minority of patients who actually do present with symptoms, like 5 to 10% of them. And the classic B symptoms are such a staple on the boards.
Oh, you have to know them cold.
Right. We're talking unprovoked fevers over 100.5 Fahrenheit for more than 2 weeks, drenching night sweats, and greater than 10% unintentional weight loss, plus extreme fatigue.
Yeah, and you'll find physical evidence of where these cells are hiding, too.
Right, the lymph nodes.
Exactly. Lymphadenopathy is super common in symptomatic cases. You're looking for cervical, supraclavicular, or axillary nodes, and they have a very distinct feel for the exam. They're firm, round, non-tender, and freely mobile.
Non-tender is the key word there. And splenomegaly is the other big finding, right? It's in like 25 to 55% of cases.
Yeah, as the malignant lymphocytes infiltrate the spleen, it gets incredibly engorged, and that leads to sequestration of normal red blood cells and platelets, which causes anemia and thrombocytopenia.
Let me push back on this logically for a second, though. Because if a patient's blood is absolutely flooded with B lymphocytes, I mean, literally hundreds of thousands of them, shouldn't their immune system be practically bulletproof?
You would think so, right? That is the ultimate exam trap.
It feels so counterintuitive.
It totally does, but the reality is the exact opposite. These mature-looking B cells are entirely dysfunctional. They are malignant clones, so they don't do their job.
I'll just take up space.
Basically, yeah. And this leads to profound hypogammaglobulinemia. So instead of being bulletproof, the patient is incredibly vulnerable. They're a sitting duck for encapsulated bacteria like staph, pneumococcus, and then also viral reactivations like herpes.
That's wild. So the leukemia itself isn't what gets them, usually.
No, routine infections are the major cause of morbidity and mortality. Oh, and there's a dermatology connection to mention here, too.
Oh, right. Leukemia cutis.
Yeah, skin lesions on the face. And they also have these wildly exaggerated reactions to simple insect bites.
Ah, because their immune system is just completely out of whack.
Exactly. It's a great little trivia fact for the boards.
Okay, so once you suspect CLL clinically, maybe you feel those firm nodes or you see that incidental CBC showing an absolute lymphocyte count over 5,000, how do you decisively prove it on the exam?
The absolute first step is the peripheral blood smear.
Right, looking for the classic smudge cells, or basket cells, some people call them.
Yes.
I always liken smudge cells to overfilled water balloons. Like they're so fragile and defective that when the lab tech literally just tries to smear them across the glass slide, they just burst.
That's exactly what happens. It's an artifact of the slide preparation because there's enough. You have to confirm clonality, and for that, you need flow cytometry.
Flow cytometry, got it.
Yeah, it proves that all these B cells are monoclonal, usually expressing just one type of light chain. And the classic immunophenotype you need to memorize is the co-expression of standard B cell markers, so CD19, CD20, CD23, alongside CD5.
Right, and CD5 is normally a T cell marker, so seeing it on a B cell is a huge red flag. Now, what about a bone marrow biopsy? Is that strictly required?
Not strictly required for the initial diagnosis, no. But if it is done, seeing greater than 30% lymphocytes confirms it. And you really want to pay attention to the pattern. A diffuse pattern on biopsy indicates a much poorer prognosis compared to a nodular or interstitial pattern.
Okay, so if flow cytometry gives us all these exact markers, why is it standard practice to also do FAESH testing on these patients? Like fluorescence in situ hybridization, why do we need that?
Because FAESH testing isn't just a diagnostic formality. The genetic results literally dictate the patient's entire prognosis and ultimately whether you treat them at all.
Oh, okay. It's about risk stratification.
Precisely. You are looking for two incredibly high-risk, unfavorable prognostic factors, the 17p deletion and the 11q deletion.
The 17p deletion, that's the one that mutates the TP53 tumor suppressor gene, right?
Yes, exactly.
I always think of P53 as the factory quality control inspector.
Yeah.
Like, if defective DNA comes down the line, P53 pulls the alarm and forces the cell to die. But with a 17p deletion, you effectively fire the inspector.
That's a perfect way to look at it. The cell accumulates DNA damage and never dies. And the 11q deletion works in a similar way. It deletes the ATM gene, which is the sensor that actually wakes up P53.
So the alarm is disconnected.
Right. And this matters immensely for treatment because standard chemotherapy relies on causing DNA damage to trigger apoptosis. If you have those deletions, standard chemo is practically useless.
You're just poisoning the patient without killing the cancer.
Exactly.
Wow. Okay, so that leads us right into staging and management. On the boards, they use the modified Rysowitsky staging, right? At least in the U.S. and Canada.
Yeah, the Rice staging goes from stage 0 to stage 4. Stage 0 is just lymphocytosis. Stage I adds lymphadenopathy. Stage 2 brings in hepatomegaly or splenomegaly.
And then stage 3 is when the marrow is so packed it causes anemia.
Right. And stage 4 is complete marrow failure leading to thrombocytopenia.
Okay, so here is a huge practical clinical point, and something students really struggle with on the exam. It feels incredibly counterintuitive and frankly terrifying for a patient to tell them, hey, you have leukemia, but then we're just going to send them home to watch and wait.
I know, it sounds crazy.
Yeah, it does. How does a student justify choosing no treatment on a multiple choice question?
You justify it by looking at the clinical data. Early stage, asymptomatic CLL-SU stage 0, I, or sometimes EI, has zero survival benefit from early treatment. The disease is so indolent that survival can range from 10 to over 20 years.
So giving them aggressive chemo early on is just an unnecessary risk.
Exactly. You'd just be destroying their already weak immune system for no reason. You only intervene when there's active disease.
And what defines active disease for the exam?
Things like severe debilitating fatigue, the B symptoms we talked about, symptomatic cytopenias, or a rapidly doubling lymphocyte count. Like if it takes less than 12 months for their count to double, you treat.
Okay, so that watch and wait trap is huge. Don't treat asymptomatic early-stage patients. Got it. But what about complications? What exam traps are hiding there?
Two big ones to know. First is autoimmune hemolytic anemia. Since their immune system is totally dysregulated, they can make autoantibodies that attack their own normal red blood cells.
Right, so you'd see a positive Coombs test.
Yes, positive direct Coombs test. And the second, which is the most feared complication, is Richter's transformation.
Richter's transformation.
Yeah.
That's when this slow, indolent disease suddenly mutates into a highly aggressive, diffuse, large B-cell lymphoma, right?
Exactly. So if you have a vignette where a stable CLL patient suddenly spikes high fevers, their lymph nodes rapidly explode in size and their LDH levels skyrocket.
Immediate red flag.
Yes, you have to suspect Richter's. The prognosis drops dramatically, and they need immediate aggressive chemo.
Okay, this has been an incredible breakdown. Let's do a quick recap. The typical MCCQE patient profile for CLL before we wrap up.
Sounds good.
You're looking for an elderly, completely asymptomatic patient. They have an incidental lymphocytosis on a routine CBC. You smear it, you see fragile smudge cells, flow cytometry shows CD5 positive B cells, and your primary management strategy, unless they have active disease, is to watch and wait.
Perfect summary. That is exactly what you need to hold on to for the exam.
Awesome. And, I want to leave you, our listener, with a final reflection on the pathophysiology here. If the core problem in CLL is that these B cells have mutated to evade apoptosis, like they've effectively just forgotten how to die, could the future of curing this quote-unquote incurable disease lie not in destroying the cells with toxic chemicals, but in finding a biological switch to simply remind them how to self-destruct?
That's really the holy grail of targeted therapies.
Right. It's something to ponder as you review your pharmacology and targeted treatments. It totally shifts how you think about cancer.
It really does. Keep up the great work in your exam prep, everyone. You've got this.
Absolutely. Keep studying hard, and we'll see you on the next deep dive.